Good morning and good afternoon, everyone. Welcome to our webinar, Monkeypox in the Global Context, Combating Racism and Intersectional Stigma. My name is Ingrid Katz, and I'm the Associate Faculty Director at the Harvard Global Health Institute. More than 32,000 cases of monkeypox virus have now been identified across nearly 90 countries. Vaccines and treatments are being rolled out by health agencies around the world, most of which are responding to the significant monkeypox outbreak within their own country. Once again, we are seeing African countries that have been managing monkeypox outbreaks for more than 50 years being left behind, with decisions on resource allocation for testing and treatment being made and prioritized for high-income countries in Europe and North America. Additionally, the early outbreak response has bared a striking resemblance to the early HIV response. We've seen the use of harmful and stigmatizing language, widespread circulation of images of African bodies with rashes, and the conflation of sexuality and monkeypox infection. During the panel discussion today, our experts will consider how intersectional stigma and racism have shaped priorities and undermined strategy in the global response to the monkeypox outbreak. Panelists will draw on the successes and failures of prior pandemic responses to discuss how bias limits the efficacy of public health strategy and how equitable, evidence-based approaches can protect the health of all. Before we get started, I just have a few housekeeping notes. This session is being streamed and recorded through Zoom, and the recording will be made available on the Harvard Global Health Institute website afterwards. We will devote time at the end of the panel discussion to answer attendee questions posed during registration and during the course of this session. So if you have a question for our speakers, you may use the Ask a Question feature on the bottom of your screen, and we will do our best to answer them during the Q&A portion. We've also enabled the chat function, which will be monitored by my colleague, Carissa. So to get started today, we'd love for everyone to use the chat to share where you're calling in from. Please feel free to include the city and the country. I'm calling in from Cambridge, Massachusetts. As you're putting those notes in the chat, I'd like to take this opportunity to introduce our tremendous speakers today. Professor Jean-Jacques Mayombe-Tamfam is a Congolese microbiologist. Born in the DRC, he studied at the Médecins at Lovanium University, where he obtained his medical doctorate degree in 1962. He was then trained for a PhD in virology at the University of Louvain in Belgium. Upon his return to the DRC, he was appointed as professor and head of the Department of Microbiology at the Faculty of Medicine of the National University of Zaire, and in 1978, he became dean of the faculty. He currently serves as the general director of the National Institute of Biomedical Research of DRC. He is best known for his early contributions to the discovery of the Ebola virus, and since then has been on the front lines of Ebola research, most recently related to the discovery of the current most effective treatment for the Ebola virus. Professor Mayombe's scientific contribution is not limited to the Ebola virus. He's created a research and surveillance infrastructure on vaccine-preventable diseases such as polio, measles, and yellow fever, and on zoonoses such as monkeypox and viral hemorrhagic fever, and on acute respiratory infections such as influenza. He has served on the Faculty of Medicine at the University of Kinshasa for over 40 years, training over 1,000 researchers in the DRC. Our second speaker is Dr. Bahume Kabisan Titanji. She is a Cameroonian-born physician scientist and an assistant professor of medicine at Emory University in Atlanta. She obtained her medical degree from the University of Yaoundé in Cameroon and has worked for 2 years after graduation as a medical officer before pursuing postgraduate research training in London. She obtained a master's degree in tropical medicine and international health from the London School of Hygiene and Tropical Medicine, a diploma in tropical medicine and hygiene from the Royal College of Physicians, and a PhD in virology from the University College of London. She joined Emory University School of Medicine in 2016, where she completed a residency in internal medicine on the ABIM research pathway and a fellowship in infectious diseases. She has 3 parallel career interests: translational and clinical research in HIV and emerging viral infections, scientific communication, and global health. And her clinical focus is on infectious diseases and people living with HIV. Our third speaker is Dr. Coletzo Machofane. He is an FXB Health and Human Rights Fellow here at Harvard University. He is a public health researcher and activist who works in the global HIV response with a focus on sexual minority men in East and Southern Africa. He is a member of the Governing Council for the International AIDS Society and sits on the board of LVCT Health, a leading HIV service organization in Kenya. He also sits on the founding board of Global Black Gay Men Connect, an activist collective that aims to build power to stop discrimination and violence inflicted on Black gay men around the world. Dr. Machofane has served on various working groups and committees that shape the global response to HIV. And these include the Guidelines Development Group for the first comprehensive WHO guidelines for HIV prevention, diagnosis, treatment, and care for key populations, and the IAS Lancet Commission on the Future of Global Health and the HIV response. And lastly, our moderator, Helen Branswell, a senior writer at STAT covering infectious diseases and global health. She joined STAT at its founding in 2015. Helen was introduced to epidemic reporting during the 2003 SARS outbreak. And in the year since, she's written about bird flu, H1N1 flu pandemic, Ebola, Zika, polio, and measles, and is now leads STAT's coverage of the coronavirus pandemic. Helen spent the summer of 2004 embedded at the CDC as a CDC Knight Fellow, and in 2011, a Neiman Global Health Fellow at Harvard. In 2018, she won the AHCJ Award for Best Reporting, and was the recipient of the 2020 George Polk Award for Public Service for coverage of the COVID-19 pandemic, and was awarded the 2021 Victor Cohn Prize for Excellence in Medical Science Reporting. And with that, I will hand it over to Helen to lead our panel today. Thank you.
Thank you, Ingrid, and welcome everyone. We have a really, I think, interesting hour ahead of us, and I want to get right to it. So without further ado, I'm going to ask Dr. Mayembe to make some opening remarks.
Okay, greetings and thanks for inviting me to join this webinar on monkeypox in the global context. I am proud to share with you my experience on monkeypox from DRC. Monkeypox is a zoonotic disease caused by monkeypox virus, which is endemic in Western and Central Africa. And the disease is clinically similar to smallpox. Monkeypox disease was described for the first time in captive monkeys in 1958. The first human case was detected in 1970 in a child from Basankusu village, Equatorial region in DRC. Monkeypox is characterized by an incubation period of 4 to 17 days, followed by a short prodromal period with fever, headache, sore throat, lymphadenopathies, and a rash period with skin lesions progressing from macule to papule, vesicle, pustule, crust, and desquamation in a centrifugal distribution. The other signs are gastrointestinal symptoms such as nausea, vomiting, diarrhea, and so on, And the common complication are bacterial superinfections with bronchopneumonia, encephalitis, sepsis, ocular infections, and dehydration. The fatality rate is up to 11% in unvaccinated individuals. Monkeypox can be confused with chickenpox cases. The history of monkeypox started in 1970 when the first human monkeypox case was detected in the village of Sankusu, while the country was engaged in the smallpox global eradication program. In 1977, smallpox eradication was certified in DRC. And in 1980, the 33rd Health World Assembly declared the global eradication of smallpox with cessation of smallpox vaccine. The government of DRC and WHO were concerned by the emergence of this new disease, clinically similar to smallpox. It is why in 1981, 1986, a surveillance system of monkeypox was implemented by the Ministry of Health of DRC for passive surveillance, and the WHO was active surveillance of monkeypox in DRC and Western Africa. 90% of cases were reported by DRC. In 1987, this program was discontinued with the conclusion that monkeypox was not a threat that can jeopardize the achievements of smallpox eradication. But in 1996, there was an outbreak of monkeypox cases in Katakokombe in the Sankuru district with more than 500 cases. In 2004, it is why in 2004, 2007, we organized an active surveillance of monkeypox in the Sankuru province. Two main conclusions were drawn. First, there was a 20-fold increase in transmission of monkeypox compared to the 1980 surveillance system. The second is vaccinated persons were at lower risk of infection than those not vaccinated. In addition, in 2011, 2015, we organized with CDC and announced monkeypox surveillance in the Chapa province. The main findings were that non-human primates were the most source of exposure, followed by rats and squirrel. There was an increasing proportion of cases attributed to human transmission. And finally, in 2017, 2018, monkeypox was notified by Nigeria after 39 years, during which no cases were reported. And now, in 2020, multi-country outbreak with, as of 11 August, there are 31,799 cases globally, and most of these cases were reported by the countries that have no historically reported monkeypox. And now the challenges we face too in DRC. The first is the patient management. Monkeypox was a neglected disease without a specific drug or vaccine. Only palliative treatment was used. It is why most patients will stay hidden in the community and didn't come to the hospital. Second, the disease detection and confirmation. At the beginning, clinical specimens were collected and sent outside the country for diagnosis, mainly in Germany and at CDC Atlanta. But now we have succeeded in the transfer of technology, and we can perform the diagnosis locally. But what we need is rapid tests because most of the cases occur in the remote areas. Three, understanding of the zoonotic host, the reservoir or vector of monkeypox. We observe that rodents and non-human primates are, in fact, the victim of the disease and not the reservoir of the virus. So we have to look for the reservoir of the virus in nature. And for epidemiological surveillance, the DRC system is very weak. In addition, monkeypox outbreak occur in remote areas, difficult to access. In addition, we have also, most of the time, shortage of sample collecting kits. We have logistic problem for storage and transportation of sample to the National Public Health Laboratory located in Kinshasa. It is why it is difficult to decide what is the real magnitude of the transmissibility of monkeypox in DRC.
Dr. Mayembe, I'm sorry to interrupt. Could I ask you to, could we leave it there and raise some of these other questions after the other speakers have made their opening remarks, please?
I conclude that.
Okay, thank you.
I conclude. When I was a young postdoc student, I joined the WHO team in charge of epidemiological surveillance of monkeypox in Africa. And today, 46 years later, I could imagine that monkeypox will be declared one day a public health emergency of international concern. This is a big lesson for me, and I think also for all of us. Thank you very much.
Thank you. And indeed, that it is a big lesson for all of us. Thank you for those scene-setting remarks. Can we now go to Dr. Titanji for some opening remarks?
Thank you so much for having me on this webinar on this incredibly important topic. And just following up on what Professor Mayembe has so clearly laid out, we have now seen monkeypox, a disease that we have known has been in existence and circulating primarily in West and Central African countries for over 50 years, shifting to be essentially a global public health emergency. And in that shift, what I have also observed is a shift in the urgency in how we are responding to monkeypox. One can almost say that monkeypox in Europe and in North America is being treated like a completely different disease compared to how it's been treated in Africa over the past 52 years that we have known that this was a virus that was capable of causing human disease and also rapidly spreading in increasing proportions and causing bigger outbreaks through the years. On July 23rd, the WHO declared a public health emergency of an international concern pertaining to the monkeypox outbreak that has now spread to affect almost 90 countries. But essentially what we have seen in the almost 1 month period since that declaration is that it seems like monkeypox is a public health emergency in Europe and in North America. And a lot of the response has focused the resources that are available primarily in these countries that are newly affected, relegating countries that have had to contend with these outbreaks through the years essentially to a footnote. We have heard from Professor Muyembe the multiple barriers in terms of adequately responding to the monkeypox outbreak, barriers in terms of resources for surveillance, in terms of access to treatment, which is still palliative and supportive in parts of Africa, and also barriers in terms of diagnostics to even define the magnitude of the problem. If we do not define the magnitude of the problem, how then can we prioritize and adequately allocate resources to where they need to go? And I would close by saying that in the ongoing outbreak, we are seeing emerging monkeypox spread in ways that have not been fully characterized before. And we need to understand these new modes of transmission in countries that have historically been affected by monkeypox. And we know that right now there are communities, primarily of MSM, who are disproportionately impacted in the current outbreak. And as we think about the response, we must also think about how we address research around new modes of transmission, particularly when you consider the fragility that some of these communities face in countries where LGBTQ folks are criminalized. And I would stop there for now. Thank you.
Thank you very much. And now we're going to go to Dr. Machofane for some opening remarks.
Thank you for having me, and such a privilege to be on the same panel as Dr. Titanji and Dr. Muyembe. I'm sorry for butchering your name, sir. I want to point out that monkeypox is happening in a marginalized population across different settings. And so we have to talk about it with some care. So mostly what I'm going to talk about is homophobia and how I've been engaging with the idea of homophobia. I am leading, along with 18 or 19 members of our community, a study to measure monkeypox symptoms in New York City. And because we're kind of very few people doing this kind of work, we've had a lot of press. And I'm going to tell you the kinds of questions that I've had about homophobia. There are three. One is, should we start talking about how this outbreak affects primarily gay and bi men and maybe trans people? And the answer is yes, and we have been from the very beginning. So that question is a confusing one. The second question is, do you think public health agencies should be telling gay and bi men to have less sex, fewer partners, to change their sexual behavior in some way? Yes, with a big caveat. Sometimes when people do that, they smuggle in messages about the sex itself. And sometimes they're aware of that smuggling in, sometimes they're not. And those messages are negative because we live in a world which thinks about gay men and sex and gay men having sex as not normative, as something to be changed, something to be addressed, something to be fixed. So one question which I am very interested in, that I think is urgent at this moment, especially in the countries that are bearing the new burden of monkeypox, is whether we think, and this is a question few journalists have asked, whether we think that homophobia has something to do with the slow response to monkeypox in the US, in other countries that are now experiencing monkeypox for the first time. And that question is at odds with what we've just heard, that in fact there is a very much a slower response to monkeypox in the countries that have borne the burden of monkeypox for a long time. And I think we can't resolve that. We just have to sit with that tension. On one hand, in a country where people are marginalized and where there is a policy environment that's getting worse and worse by the day, children are being attacked, which means we're next. There is a discourse around grooming children. And so queer people are at risk of serious violence, notwithstanding the pain of monkeypox itself. So we have to address that as it is, as a marginalized population, even at the same time as we say, how can it be that one country owns most of the vaccine for this one disease, and what are we going to do to make sure that people who have been experiencing monkeypox for years, for decades, you receive an equitable response. We have to keep those two realities in our minds, even though they appear to contradict each other. But we live in a world with where LGBT people have worse health, and this question of whether the response to monkeypox should be considered a homophobic one, I think we should address as a community, and we should borrow tools from scholars of structural racism who think about racism, who theorize about racism. And what I think is important to borrow from these scholars is the idea that racism can live in institutional structures and practices. You don't have to have anti-gay animus between individuals. You don't have to see a smoking gun. You need only look at health outcomes, experiences of health access, and see whether this group of people is at a disadvantage, and it is. So as we enter this phase of monkeypox in the newly affected countries, which comes on the heels of a failed emergency response, and now has to be much more of a protracted response around which we must organize resources, we have to be mindful of the fact that we haven't finished with HIV. So the same things that structure HIV in this population are going to structure monkeypox: treatment, prevention, access to services, access to care. And so the question of homophobia, while most people think about it as a question related to how we talk about gay men and monkeypox and bi men and trans people, we have to expand that frame to include what do our governments owe us, and have they lived up to that promise that as citizens of whatever countries we're in, we are protected in the same way as everyone else. In fact, in a way that recognizes that we are oppressed, therefore we need more care to live healthy lives. So I'll pause there and look forward to discussing with you all.
Thank you. Really interesting remarks and really big issues to address here. I'm going to jump in based on something that you've just said and ask, you mentioned, what do our governments owe us? One of the things that strikes me about this outbreak is there are conflicts. Dr. Titanji mentioned them earlier in her remarks about how this has become a crisis because it affects countries in the global north, affluent countries. The reality is there are limited supplies of vaccine. They're owned almost exclusively by one country in the United States because that country financed the development of the vaccine. Everybody talks about the need to share. Everybody talks about the fact that African countries haven't had any access to vaccine. But yesterday I was reading an article that mentioned the fact that the US government had made the fatal mistake of allowing Bavarian Nordic to sell some of the US doses to other countries. How does one balance the global needs here? How is a government responsible both to its populaces and to all of the other countries that need access to vaccine? If anybody can jump in here.
So I'll go first. I think we should firstly recognize that this is a completely manufactured shortage of vaccine. Had the US government acted quickly when we saw the first signs that monkeypox is spreading and is increasing exponentially, even though the numbers were less than 100, had we acted with some urgency in the US and abroad, we might have averted this whole conversation. So we have to recognize that there are some people who are making this is not a natural disaster. There are people who are in charge of making decisions who fail to make the right decisions with respect to people's health, particularly people. I mean, so we are all responsible for each other. That's what I believe anyway. So I think the US government does owe people around the world an extension of the health resources that it has, because all of us deserve to be healthy. It doesn't make sense for me to deserve more health once I cross the border into the US and less health now that I'm here in South Africa. But I also think that we are coming up against a nationalism that we haven't really dealt with as a global health community. And rather than asking what governments should do politically, I think we have to ask ourselves how, as people who are in global health, including activists, including doctors, including academics, can come together and first of all, envision a fairer system of distributing these resources, and secondly, apply pressure to these governments to do what is right, because they are not going to do that on their own.
Dr. Titanji, Professor Moyembe?
Yeah,
Thoughts?
I would like to add to that by saying that the stockpiling of smallpox vaccines through the years following the eradication of the smallpox virus was intended because there was a concern that we could still in the future be faced with a smallpox outbreak if the stocks that are held by 2 countries around the world tended to be released like a biological weapon. And with seeing what has happened with monkeypox in terms of the shortages of vaccine, I think that one of the questions that I ask myself is the stockpiling and preparedness. Who was that for? Was that only intended for a subset of countries? Or were we envisaging a situation where if smallpox did in fact make a return, there would be enough vaccines to actually cater to a global need? I think that that is really a crucial question to reflect upon, because, you know, with the world as interconnected as it is right now, it is completely impossible to imagine that if smallpox were to make a return and emerge in Europe or in the US, that it would stay there. And I'm making this point to drive at the fact that where the failure happens is the failure to prepare, and not only to prepare for outbreaks of infectious diseases from a nationalistic standpoint, but really to start thinking about these outbreaks as outbreaks that affect us all. And the preparedness must factor in that when these emergencies do occur, we would have to have these resources to tackle them everywhere simultaneously. And we are again faced with a situation where we are being reactionary. If there was ever a prototype of an infectious disease that we were in the ideal situation to respond to, that would have been monkeypox. We had the tools, in quotes. We had antivirals with potential, in quotes. But now we are actually in the eye of the storm, as you might describe it. And here we are again, having to think about shortages in those purported tools and why those tools are only available to a small minority.
Yes, that is very interesting. I mean, as a journalist, I read a lot of, stories about what's going on with monkeypox. And one of the things that strikes me is that oftentimes people are framing it in, how do we stop it in our country? Which is so short-sighted, because if we don't stop it in all the countries, it doesn't really matter if the United States stops it for a little while, it will come back. I wanted to ask Dr. Moyembe about the issue of vaccine access and in particularly for your country, which has been, I think, the hardest hit by monkeypox over the years. Is there any indication that there will be availability of vaccine for your country, and how would it be used?
Yes, when I remember what happened with COVID, with the COVID, African countries were the last to have the vaccine. So, fortunately, the disease was not so severe in Africa. So we survived. Otherwise, it has been a very, very big problem. because all the vaccine was for Europe and America, and Africa was neglected. So my fear is that with monkeypox is endemic disease in DRC and in Africa. And we have a lethality, a case lethality, a rate lethality, what do you say? Lethality,
Case fatality
rate, yes, of up to 11%. So it is a severe disease. And we need vaccine. If we have vaccine, we will use the ring vaccination, like we did in case of Ebola, to vaccinate the contact of positive and the contact with the contact, mostly in the families, in the household, in the household. So this is very important. And also to protect the healthcare workers in the hospital. And so it is what we think to do. And we here at my institute, we are ready to conduct some clinical studies, clinical trial with the new vaccine we have now, mainly the Jonas vaccine, ACAM 1000 vaccine, and also the LC16M8 vaccine. So it is very important for us to have the same level as in Europe and America. So the equity in sharing vaccine is very important. It is a very important message we have to give in this webinar.
Are you getting any indication that you're going to have access to those 3 different vaccines to conduct the clinical trial?
For the moment, I have no indication, but I think it will be so because WHO is working in this direction, and I think it will be okay. It will be totally different of what we saw with COVID-19.
Dr. Machofane, you had wanted to jump in, I think.
Yes, I was going to respond to the idea that separate countries are treating this as if it's not an infectious disease that does not respect borders. And, you know, I wanted to say, first of all, again, with the questions from journalists that I've had more interviews in the last few weeks than in my life. And it's been really striking how, first of all, the idea of monkeypox being endemic has been a way of not engaging with the continuities between what's happening in Central and West Africa and what's happening in Western Europe and North America and other countries. And so I've been really my campaign has been to tell everyone to try and write the article without that word and then maybe use it if you need to use it. But to explore and ask, is Nigeria an endemic country, or are we in the same outbreak that started in 2017 in Nigeria? And the reason it's important for journalists to do that is that it can allow everyone else to have those tools, to have those ideas, to connect what's happening over here with what's happening over there. What I felt like is going on, especially among the activists who are responding, is that it's so immediate. There are friends of mine who are saying, hey, I know you're in public health. I think I have monkeypox. It's the most painful thing I've ever experienced. I need relief now. So, so I'm going to respond to what's in front of me. And I think that is definitely going on. It's something we need to address, the idea that we are responding very locally to something which is a global phenomenon. So all of us, I think, have the responsibility of saying, for everything you say, everything you write about monkeypox, to make the connection between what's happening here and what has been happening in Africa, because it didn't come out of nowhere, it comes from there. So if we don't understand what's going on there, how can we possibly understand what to do about what's going on here?
And I will just like dovetail with what Dr. Machofane has just said, to say that one thing we forget is that in the current outbreak, what we're seeing is circulation of the clade 2 strain of the virus, which is the one that has circulated historically in Western Africa. However, there's still a different clade of the virus, clade 1. And, you know, countries that have access to the tools that they are deploying currently may yet succeed to contain the monkeypox outbreaks within their borders. But that does not mean that we're not going to see outbreaks of a different clade of the virus happen years down the road if we, after containment is achieved in Western Europe and the US, again revert back to the mindset of it's their problem and it's not ours.
Excellent point. I wanted to ask Professor Muyembe, what can the countries of the global north do to help your country, and not just the global north, because there's scientific expertise throughout the world. What help does your country need to further figure out, you know, what the true reservoir is? Pardon me, you may be hearing a siren in the background. Can't help that. What the true reservoir is, how spillovers are happening, how spillovers could be minimized, and how people in DRC can be, and other countries in Africa can be protected against monkeypox.
Yes, in DRC, we have good collaboration with scientific institutions like CDC, Atlanta, NIH, UCLA, and Institute of Tropical Medicine in Belgium, and IRD in France. And also we receive support from JICA, this Japanese international cooperation. So the first thing is to have a good idea, to have coherent findings on the epidemiology of monkeypox in endemic countries. What is the role of animals? We call animals reservoir, but for me, most of these animals are victims like human. They are infected, and they will transmit the disease because they are infected. So we have to understand exactly what is the magnitude of the disease, the prevalence study in the country, and also to have a rapid test, because rapid test for the diagnosis, because the disease often occur in very remote areas. So they don't have lab there, but we need them to be able to detect as early as possible an outbreak of monkeypox in this area. And for the vaccine, we need vaccine because the disease, most of the time, the disease is severe and lethality is high. So it is very important to protect population, to protect the family members, the community, and so on. But the priority is the healthcare workers in the hospital and so on. So there is a lot of needs. It is difficult to mention all of them, but we have some experience to manage these outbreaks in our countries in Africa.
Thank you. Dr. Machofane, moving beyond communications, although communications hasn't been sort of stellar, I think, in this outbreak, it's important to consider public health practices and how this is impacting the LGBTQ community and people of color. What are you seeing happening, and how can public health and the medical community counteract the barriers, the stigma that people are facing?
I think that we should acknowledge that homophobia structures life, just like racism structures life, sexism structures life. And acknowledge that homophobia doesn't only operate in settings where there are criminal laws on the books. South Africa is a country where there are no criminal laws on the books, but there is a very alive homophobia.
Leads to people being harmed. So I think that one of the things that we have to develop is a language to talk about the homophobia of having a stockpile of vaccine, seeing people start to get this new disease, and it is new to the extent that it's presenting in a way that's different than it has before. And it's presenting in a specific subpopulation, and it seems to be associated with sex, which means that we're going to have a very difficult time talking about it. But we need to understand that the idea that someone can sit on this vaccine while people are saying they're experiencing the worst pain of their lives and wait to see what happens, that's homophobia. So if we don't talk about it that way, if we don't talk about the decisions and the policies that structure what's happened so far and what might happen in the future, we won't manage to counteract it. We won't manage to organize ourselves. And like I said earlier, I fully do not believe that governments are going to step in and rescue LGBT people, right? That's not a reasonable assumption. If you think about HIV, if you think about just the level of violence against LGBT people, if you think about the turn towards conservatism and the turn towards the kind of criminalization of not just queer people, but women's bodies. All of that stuff is in the soup that is toxic. And so we as researchers, we as people who are activists need to make sure that we aren't waiting to be rescued. We need to start making plans to intervene in our own communities. And what I think, and I'm not saying anything that people who live in these countries don't know. The activists are already doing activism. But what I think is missing is a global understanding of this illness, an impulse to connect across countries, and specifically like we're doing here, and this is kind of amazing and important. So thank you to the Institute for putting together this panel. We need to connect with folks who have been thinking about monkeypox and working on monkeypox in Central and West Africa, not in the patronizing way that we have been for HIV. And I say we in a very, it's not actually my fault. I don't come from the US. It's the people who come from the US who are funders, but are also people who are affected by the things that they fund. And that confuses people because it seems like you can't learn then from what is happening in what experts in Central and West Africa have done. We need to be able to learn from them, from wherever we are. So my plea is that we think about the policy failures as a symptom of homophobia and treat them as such. And that as we respond, we don't wait to be rescued, and that we form connections across countries and form new ideas, new ways of working together across countries. We are more connected now than we have ever been before, and we have to shift. We have to shift and recognize that even as people who don't have a UN or some kind of platform to do, and I mean, we don't, as an activist, don't have one central place to go to meet across different countries, different contexts to talk about shared problems. We need to make those structures at this point.
I was hoping that Dr. Titanji, you could jump in and sort of address the same question.
Yes, I would like to add to what Dr. Machofane said by saying that, you know, in the same way that we have seen a lot of the slow rollout of interventions in newly affected countries track along the lines of homophobia and discrimination towards the LGBTQ folks, I think that the same tracking along fault lines of inequity is also reflected in the fact that the delay in getting vaccines to Africa and diagnostics to Africa, and all the things that Dr. Muyembe laid out that are needed right now, is reflective on the fact that we still place a lower value on the lives of brown and poor people in countries that have limited resources. And that is, monkeypox is just highlighting that again. Coming right outside of COVID-19, we know that from the ongoing pandemic, when you look at those who were most affected, even in those countries that are resource rich, again, the disparities tracked along the lines of minoritized communities. And so we can't claim that we are surprised that we are seeing these trends again with monkeypox, because we know that these trends exist and we know that has been shown in previous outbreaks. So I think that in order to address that, the mindset must shift. At the time when we are responding to an outbreak of a new infectious diseases, we must already have in mind that there are people who, by virtue of being who they are already disenfranchised before the outbreak happens. And the response agenda must very clearly address how are we going to reach these populations? How do we make sure that in the response, they are prioritized? Now, I'll take the context of monkeypox within the US, in the state of Georgia, where I practice as an infectious diseases physician. What we are seeing now is 70% of cases are in Black MSM. However, when you look at the vaccination numbers, 45% of vaccinations are going to that population, whereas white MSM represent 15% of the cases, but are getting more vaccines than the highest group that is being affected in this context. Again, tracking along those lines of people who are historically minoritized, historically disenfranchised. And, you know, even before the data were released yesterday by the Georgia Health Department, I don't think any of us in this space could say that we were surprised by it. But I can say that it is appropriate to say my response is I am shocked by the fact that we continue to perpetuate and allow these things to happen, attending to the needs of those who are most disenfranchised, putting them at the bottom of the list in terms of our responses.
Thank you for that important point. We're almost out of time. I'm just going to do a quick round robin and give you each a chance to make one last point, but please keep it very brief. I'm going to start with you, Dr. Muyembe. Is there a point that you would like to make that you want people to think about as they are leaving this discussion?
Monkeypox has been for a long time neglected disease for Africa. And now it is a disease, this international disease, this is a global disease. And what we think is that we will share the equity, we will share vaccine and drugs that we need to treat and to prevent the disease in Africa. Thank you.
Dr. Machofane.
I would say that we have learned a lot in the HIV response, and we need to engage with those learnings, because these problems of inequity, problems of having people who are remote and how to reach them, problems of subgroups that do not engage with clinical services as they are set up, so you need to develop some other alternative structures. These are problems that are the bread and butter of the HIV response. The challenge is going to be that the burden is now in higher income countries, at least of this new form of monkeypox. And these countries or people who work in these countries have difficulty learning from places that they think they can teach but not learn from. And so the challenge for them is to find experts in Africa who have worked in HIV, who work in monkeypox, who can think through the problems that we are seeing, including problems of the health system, problems of insurance, for example, in the US, problems of doctors turning away patients who present with pain or leaving them untreated with pain. Those problems are not new. Those are not new things to think about. So to the extent that we can learn from folks who've done this work, and those folks are in Africa, the majority of them, we can move faster in coming to solutions about monkeypox. And it's urgent that we do this because we are exercising a muscle that we're going to need. We are in a time where there'll be more and more new infectious diseases. So it's important for us now, notwithstanding the health of the people who are being affected, both in Africa and in Western Europe and North America, we need to be able to succeed here, because if we fail here, what's going to happen when the next thing comes?
Important point. Dr. Titanji, last word to you.
Yes, I would say that, the words global health equity would remain meaningless until we actually back them up with action. And we've had multiple trial runs during which we have essentially failed to actually live up to what global health equity means. We know that pox viruses are incredible pathogens that can become very successful. Smallpox caused an estimated 300 million deaths globally, and it's a conservative estimate. In order for monkeypox to not become the next orthopox virus that gains that level of success, we have to learn lessons of the type of global coordination that it took to be able to achieve the eradication of smallpox. The world has been able to do it before, and I think that the world can do it again, but it would require making sure that all the voices are at the table in terms of sharing the knowledge, listening from African researchers and scientists who have worked on this for years, learning from them, but also being willing to share the resources that we have at hand in order to tackle the ongoing outbreak. And until we do that, we'll continue having these conversations about the next outbreak and not make significant progress. And I'll end with that.
Important point. Thank you so much.
I want to thank you all so much, our tremendous panelists and our wonderful moderator, for these incredibly critical points. And I think Dr. Titanji summarized it so well in saying that if we are centering equity, we need to back that up with action, because otherwise it is absolutely meaningless. And all of you are leaders in that. So thank you for sharing your time with us today. Thank you for sharing your knowledge. We also want to thank our tremendous audience for participating in this. And as a reminder, this has been recorded. It will be posted as a webinar on our webpage in the coming days. Thank you all. We hope you have a wonderful rest of your day. Take care.